Did you know that the sensory supply of the pulp is mainly given by A delta nerve fibers and the C fibers, among which the A delta fibers is the more thicker one and is myelinated. The C fibers are rather non-myelinated or unmyelinated, and these are the thinner ones. That is the reason why A delta fibers are more prone to deterioration or degeneration during hypoxic conditions, as it occurs generally in pulpitis. So, and the C fibers, as in compared to A delta fibers, are more resistant to hypoxia. So if there's a condition such as pulpitis where there's low amount of oxygen concentration in the tissues due to improper drainage of the blood vessels or the blood, and also the inflow of the blood to that tissue is impeded somewhat. So that is the reason why A delta fiber will degenerate first, and after that in the late or the chronic stages of pulpitis, even you can find the C fibers still viable. And the function of A delta fibers is to carry fast pain, or it carries the pain faster, and the nature of the pain gone through this or traversing through this nerve fiber to the thalamus is rather lancinating, sharp, and well demarcated kind of pain. You can easily localize from where the pain is originating. And compared to that, the C fibers, as they are unmyelinated, they carry the pain stimuli rather very slow, and the pain kind of that arises in this is rather dull, throbbing, and poorly localized. And that is the very reason why in chronic pulpitis there is no sharp shooting pain, because A delta fibers aren't there, and instead of it, the slow or the slowly carrying fibers, that is the C fibers, are still viable, and these result in a dull and throbbing kind of pain. Hello everyone, this is Dr. Pythos, and you are watching Based Dentistry. Just to understand very well the different kind of pulpitis that we see, that is the focal reversible pulpitis, the acute kind of pulpitis, the chronic pulpitis, and lastly but not the least, the chronic hypoplastic pulpitis. The pain, the different kind of pain that are arising in each of the type of the pulpitis, or the characteristic of each pulpitis that I will describe or will discuss later on, will be solely dependent on the nerve supply of the pulp. Which kind of fibers are more associated to which one, and that will result to what kind of characteristic of pain will be dependent on these circulation of the blood and the circulation of the nerves into the pulp. I tell you that the pulp is supplied by a sensory nerve, and then there is sympathetic nerve. And before going into detail of these, I'm telling you that there is no such parasympathetic supply to the pulp. That should be kept in mind. So the afferent kind of the nerve terminals that are supplied to the pulp are originating from the trigeminal nerve, and that is the sensory branch. And in case of afferent nerves, it is sympathetic in nature, and it has action on the blood vasculature or the blood vessels, and it ultimately controls the flow of the blood into the pulp tissue. That is, it will mainly decide the tonicity of the arterioles that are going inside, or the venules that are coming out, and even the capillaries. So this is what I have grossly made this pulp tissue, and this is the somewhere there would be the dentin, and these are odontoblasts lining up the pulp cavity. This is the pulp, and this is the dentin, and somewhere above it would be the enamel. So these are odontoblasts at the junction of the dentin and pulp and dentin, and above them are the odontoblastic processes going inside the dentinal tubules. And the dentinal tubules, as my friends, we know already that there are fluids which are sensitive to motion, and that motion in the fluid of the dentinal tubules will ultimately lead to stimulation of the nerve endings, free nerve endings that are innervating them. So we are beginning with the first kind of sensory fiber, that is A delta fiber. There is one more kind of sensory fiber, that is C fiber, and these are the main supply of the pulp as the nerve tissue. And other than this, we also get to see the A beta type of fibers that have even a lower threshold than the A delta fibers and the C fibers also. The A beta fibers can be stimulated very easily and do not require any kind of strong stimuli like tooth cavity preparation or trauma or anything. These can be stimulated by mere air changes or temperature or even touch or chemical irritants, even in a lower threshold. So these are the most sensitive kind of fibers in the pulp tissue you will see. Firstly, we are going to discuss A delta kind of fibers. These are the fibers that are myelinated, as I have already drawn in the picture, and these are comparatively thicker to the C fibers. And it is known very well that the thicker the fiber is, the more oxygen it is going to require to maintain its function or viability. So this A delta fiber. The A delta fibers gets inside the tooth or the tissue of the tooth to the periapex or the apical foramen, and from that it directly traverses all through the pulp to get to the junction of the dentin and pulp and the dentin, and this particular region is called as subodontoblastic region because it is lying just beneath the odontoblast. and there it forms, there it branches. Before before this subodontoblastic layer, there wasn't any kind of branching, as I've shown you already. There's no branching below it, and after once it has reached the subodontoblastic region, it branches further, and it can either supply to the tissue, and or it can go just to the odontoblast, and or it can supply even to the innervate the odontoblast completely that is going around it, or even it can follow the odontoblastic processes all through the dentinal tubules. And researchers have also shown that it can go into the dentinal tubules as far as 150 micron. And the terminal points are unmyelinated. As you can see, the myelin sheath is up to here. After the branching is there is no myelin sheath, and that when it forms the terminal end, it is known as free nerve endings, F and E. So these are the nociceptors, or the pain carrying fibers that when stimulated generates a kind of situation that the brain will know that something wrong is going on into the tissues, so it will accordingly take action by the efferent nerves and will alter the blood vasculature. And this is how the inflammation, or the process of inflammation, is triggered because of these fibers, and the result is a compensation or a decreased blood supply or increased blood supply accordingly. We'll discuss it later on. So here's the A delta fibers. We'll just point out what are the characteristics of this or the specifications of this fiber particular. These have a low threshold compared to this one, C fiber, so it can be stimulated easily. But there's, as we have already discussed, there's one more sensitive kind of fiber that is even more sensitive than A delta, and it is A beta. So A delta has low threshold, and also A delta has one more kind of fibers. It can either have two kind of fibers, that is low threshold, and there's one high threshold. The high threshold one acts as nociceptors. What are nociceptors? That I've already discussed. Then when these kind of nerve endings or the nerves are stimulated, they alarm a kind of threat, and these are nociceptors. And if the low threshold ones are activated or stimulated, they do not cause so much harm because they are not nociceptors. So let me go through the specification of A delta fibers. It is thick in cross section, hence it is more sensitive to oxygen concentration into the tissues. Then it is lying in the dentin and pulp junction, as you can already see. This is the pulp dentin. Then it is fast pain carrying kind of. We have already discussed it, and it is found more in the pulp horns. So that's why the reason the pulp horns are more sensitive or respond very quickly to the certain stimuli, whatever is going on into the oral cavity, or whether we are preparing a tooth into the pulp horn region. And there's a fact that is that only the 10%, all these dentinal tubules are you are seeing, or whatever there are in the pulp or the pulp and dentin junction, the odontoblastic, the dentinal tubules, only 10% of the total dentinal tubules are containing the nerve ending. That means that not all the dentinal tubules you will see have the nerve ending, and not all of them are sensitive to fluid motion inside the dentinal tubules. One more, it is myelinated, we have already known, and what difference it makes whether it is myelinated or unmyelinated, that the myelinated nerves carry the pain or the whatever the stimuli be faster rate. So it has low stimulation threshold, we have already discussed. The pain sensation or whatever the sensation is, it is taken to the thalamus, and thalamus has the control over these fibers. So one more point I would like to add here is that no matter what kind of stimulus we are giving to the these nerves or the pulp, whether be it chemical, physical, thermal, or mechanical, or trauma, any kind of thing you give, any kind of stimuli you are giving to the pulp or these nerves, the brain will only appreciate it as a pain sensation. The pulp only recognizes any kind of sensation as a pain sensation. Now we are coming to the C fibers. C fibers are unmyelinated. They are deeper lying, that is, these are lying in the junction of the pulp and the dentin, whereas the C fibers are lying deeper, and it is not nearby the dentin or the pulp dentin junction, or they are not supplying the odontoblast. One more special characteristic of it is that it is heat activated. That is the reason why the tooth going through chronic pulpitis is not sensitive to cold, because the A delta fibers, those are more sensitive to cold particularly, and the C fibers are more sensitive to heat. So in the chronic stage of the pulpitis, the A delta fibers are gone and the C fibers are still there. So they are only the chronic pulpitis. The tooth having chronic pulpitis only responds to heat. And even if you are trying to do electric pulp testing or the chronic pulpitis, the tooth will not respond to this electric pulp testing, because C fibers are also less reactive or less responding to electric currents compared to A delta fibers, which are very much sensitive to electric currents. So it will respond highly. This won't respond at all. And when it comes to cold testing, the cold testing A delta fibers are very much sensitive to cold, and if you need to do cold testing on or if you want a positive feedback or stimuli after stimulating these tooth going through chronic pulpitis, you will have to give it a very less amount of temperature, that it will be in minus degrees, so that it can be stimulated, and the response will be little or minor, very less, as compared to tooth going through acute pulpitis, that is having A delta fibers that are viable and still responding. One more important, and I'll rather say the most important feature of the C fibers is the C fibers at the same time are innervating multiple teeth and multiple pulps of those teeth. So that is the reason why if one C fiber is stimulated of one teeth, many more and many other C fibers are stimulated simultaneously. So pain arising due to C fiber will resemble as if the pain is originating from the tooth besides it, or any tooth from any arch can resemble the pain occurring in a tooth. Suppose this is the 6 and the 6 means the lower first molars, and all of them are supplied by the C fibers. So pain originating in this particular tooth would resemble as if pain is originating in this tooth, or maybe in this tooth, or in this tooth, and even in the teeth of the upper jaw. It can also resemble the pain as if the pain is occurring in the upper first molar or upper second molar, say. This can be defined as poorly localized pain, or sometimes as if this pain is occurring into some other tooth, or it is feels like as if the pain is coming from some other tooth, but the pain is actually originating in this tooth, or this tooth is carious or pulpily involved. So this would be called as referred pain, because pain is from this tooth originating and it feels as if the pain is from somewhere else. So this is called as referred pain. And this is why chronic pulpitis, the pain in chronic pulpitis is rather poorly localized and can be referred to other places as well. And finally, it is thin cross section. I've already told you why oxygen concentration matters to A delta fibers more and not to C fibers. Now we are beginning with the pulpitis. So the pulpitis, first we are going to the definition of pulpitis. Pulpitis can be defined as an inflammation of the pulp that may be acute or chronic, with or without symptoms, and reversible or irreversible. Breaking this term into two again gives us pulp plus itis, that is pulp, the soft tissue enclosed within the pulpal chamber or pulp cavity, and itis, as we all know being a medico, is that it is the inflammation or inflammatory condition of any tissue. So the inflammation of pulp called as pulpitis, and pulpitis being the most common cause of odontalgia. Let me tell you that 80 to 90% of the pain originating in the oral and facial or head region is coming through pulpitis, and the most from the and this term particularly used for it is odontalgia, and odontalgia means pain related to tooth or tooth-borne pain. There are certain anatomic considerations that we have to appreciate, that why the pain occurring in a tooth is different to that of inflammation into other soft tissue of our body. So why the pulp related pain is more severe or is more deteriorating at the same time, and why it is very much critical, and why does it easily why the management of pulpitis is different from the inflammation of the other tissues. The first point being that the pulp is enclosed into a chamber or a closed cavity that doesn't allow it to completely expand or swell up. So the swelling is restricted because the pulp itself is restricted to a cavity, that is pulp cavity. Second point being that whenever a tissue is inflamed, there is hyperemia. There's an increased amount of blood flow to that tissue, and even the venules that are carrying the blood back from that tissue are more or less compressed or constricted, so that the blood stays in that particular inflamed region for quite a while. And the third point is that unlike other soft tissues, there is no such collateral supply to the pulp. Suppose if there's any soft tissue of the body, and in cases of inflammation, if one of the vessels is blocked, or suppose is obstructed, you'll get to see that there is more other. Suppose this is the tissue. this is the arteriole supplying to this tissue, and this is the venule carrying the blood back from this tissue, or there would be even the lymph vessels that drain the blood or tissue fluid too from a particular tissue. So other tissues have more options of blood supply from the arterioles, that multiple arterioles you will get to see from originating or supplying that area from various directions. And when it comes to pulp, sorry, I'm not that good at drawing. So suppose this is the crown portion and this is the pulp chamber, this is the root apex. So this is just one area from where the arterioles can get inside to supply the pulp, and there's one area that, and the same area there where the venules will come back, and these will branch into capillaries and all. So there is no such provision from where it can get its alternative supply once this supply is blocked. Once the supply is blocked, there will be acute lack of oxygen, or that is called necrosis, ischemia, and that would lead to necrosis. And necrosis, once started, is a chain reaction and will cause inflammation, and inflammation has various stages, acute and chronic, and we'll see later on how this defines the pulpitis into different stages. The pathways or the causes by which a pulpitis can occur. The cause of pulpitis, the first one is somewhat infectious, or you can say bacterial. Second one is physical. Third is chemical. And the bacterial can either reach to the pulp through cavity that has occurred in a tooth, that is, a tooth is going through caries, and that has broken crown, or has some passage through which bacteria can ultimately go to the pulp. And then there can be restoration. Broken restorations invite bacteria to lodge into that space, or even give a good pathway to the pulp for this bacteria. Tooth fracture, even tooth fracture have micro level spaces that can be used by the bacteria to traverse to the pulp and infect it. Then periodontitis, when it reaches the apex, it goes, this is the tooth and this is the periodontium, and the periodontitis will ultimately go to the apex region, and the inflammatory substances due to periodontitis, or the bacteria involved in the periodontitis, will try to leach in the tooth pulp through the apex, and that will also lead to caries or pulpitis. And even there's systemic, any kind of infection, if it is there, it can also go to the pulp and infect it. So pulpitis can occur from systemic infections as well. There's one important term, as you might have already heard of it, is anacoresis. Many of us have this misconception that anacoresis means that infection of pulp or pulpitis occurring by blood-borne bacteria or through systemic infection. What we have learned that bacteria traveling into the systemic circulation or the blood, when gets to the site of the pulp, eventually causing pulpitis, it is called as anacoresis. And my friends, this is completely wrong. What anacoresis is, this is your systemic circulation and this is your pulp cavity. So these are certain molecules or particles in the systemic blood, and this place, your pulp, has some kind of is going through an acute inflammation or hyperemia that is even reversible or non-reversible, whatever the case be. Like inflammation can also be triggered by trauma, and where there is no bacterial infection as such. But even the trauma results in a chain of reaction that is inflammatory reaction, and there will be several chemokines or cytokines. And these cytokines and chemokines are nothing but acting as magnets to various substances. Let me tell you what these substances can be. This can be metals, dyes, bacteria, or other organisms, as you already know, fungi, viruses, rickettsia family, whatever, and suppose other chemicals, various chemicals, it can be there, and even drugs. So once there is inflammation into the pulp, whether be it bacterial or non-bacterial or infectious or non-infectious, it will try to draw these substances or these molecules towards itself, including the bacteria, and this reaction is called as anacoresis. Even if it wasn't pulp, what we generally refer to as, suppose this was some other part of our body, suppose skin tissue, or our even below it the dermis. When there was an infection in dermis, suppose, and this is the tissue and there is chemokines all over it, and no bacteria until now because it is due to trauma or any other physical or chemical stimuli. Even this would like to draw these things because even there is cytokines and chemokines, because the overall mechanism of inflammation remains same everywhere, be it this or any other tissue. So even this process inviting these kind of substances or molecules to this place is anacoresis, but we do not use anacoresis only to the pulp. Pulpitis due to anacoresis will be anacoretic pulpitis, and that is just one specific thing. When anacoresis comes to our mind, we will take it as in general, not just restricted to pulp, and not just restricted for the bacteria. It can invite anything. And this phenomena, my friends, is very rare. And only even less than 1% of the pulpitis that we are seeing in our clinical cases or our clinics is due to anacoretic pulpitis, and we never know, because even if it is inviting certain bacteria, it would be in less amount or less in number, and that our pulp can fight against it very easily. There is one more important term that is even asked in questions, and it is erodontalgia. What is erodontalgia? This term was introduced first in during World War II, because there was this flying personnel who was flying up aircraft, and he conceived or received a kind of pain which was originating from his tooth, and that was because of barometric changes. That is, barometric means pressure changes. And then due to maybe it can occur if you are flying very high or in high altitudes, even when it can occur when you are at the mountains or the hills, and even it can occur when you are diving deep into the sea. How does it occur? That the nitrogen molecules are very sensitive to the pressure, or their solubility inside the blood is very much related to the pressure in the blood or in the overall atmosphere. So the solubility and dissolubility, the solubility goes less when you are at higher or deep altitudes. So that in that condition, nitrogen gas bubbles are coming out of the blood, and these when in insoluble form, these are having, or they need even more space than its previous form, so it will try to expand or put pressure on the pulp tissue or any other tissue it is inside. So basically in pulp, as it is a closed chamber, a closed cavity, it will cause pressure, but the pulp will not expand, obviously. So that is reason there will be pain in that condition, and that is called as erodontalgia. That is, this is actually a misnomer, that it is not just restricted to air. But since because the nitrogen bubbles are there, it is almost related to air, so erodontalgia term is still being used. Before going into the classification, which is rather more needs to be understand very well, we are just finishing this lecture with this sequelae of the pulpitis, that what if a pulpitis is not checked or is untreated, what can it lead to? This pulpitis untreated will eventually lead to spread of infection to periapex, that is the periapical tissues, and from which there are various infections that can occur. Cellulitis or certain space infections can cause periapical abscess. Final can form radicular cysts. Periapical periodontitis. Now, periapical periodontitis is that kind of periodontitis in which the infection does not start or initiate from the gingival tissue, rather it initiates from the periapex or the periapical region of the tooth, where the source of infection is the pulp, and once in the periapex, it will gradually retrogressively infect the periodontium and leads to periodontitis. And there is osteomyelitis in the severe most cases. And there are various more kind of infections. Those are not directly occurring due to pulpitis, but are somewhat related to or indirectly because of pulpitis. And these are sinusitis, meningitis, brain abscess, mediastinitis, orbital cellulitis, cavernous sinus thrombosis, jugular thrombophlebitis, empyema, pericarditis, parapharyngeal abscess, and Ludwig's angina. Ludwig's angina is the same thing as space infection, other than the both medullary space, submandibular space, sublingual space, and the submental spaces at the same time, simultaneously on both sides. Once again, I'm repeating that Ludwig's angina is space infection of the submandibular, the submental, and the sublingual spaces on either sides of the mandible at the same time.